Chronic cough is extremely common. It affects 10% of the world population. And almost half of the cases remain unexplained, even after extensive medical testing. I will tell you 9 secrets how to identify the real cause of the cough. We need to cough because it clears our airways from mucus, irritants and microbes, and keeps the lungs and airways clear. Without a cough, infections would spread into the lungs easily and cause pneumonia. And the lung can collapse due to secretions blocking airflow. On the other hand, excessive coughing can also damage the airways due to inflammation and cause exhaustion and pain. If a cough lasts less than 3 weeks and has no other major symptoms, it is usually harmless. The most common cause is the common cold, bronchitis, sometimes pneumonia if associated with fever, difficulty breathing, and a productive cough with yellow or greenish mucus. If a cough lasts more than 3 weeks but less than 8 weeks, it is called a subacute cough. Most commonly, it is caused by a cough after infection. For example, after a common cold or COVID-19. In rare cases, pertussis, if a cough lasts more than 8 weeks, it is called a chronic cough. Usually, it is a more serious condition. And here is the first tip. If a person coughs more than 8 weeks, but the chest x-ray or CT scan is normal, more than 90% of the probability it is due to asthma, postnasal drip or GERD, which means gastroesophageal reflux disease. It is such a huge step to exclude tens of different diseases with a simple shortcut. Now, let's say how to differentiate asthma and GERD. They are the top 2 most common causes of chronic cough. Each of them is responsible for around 30% of cases of chronic cough. If a cough worsens in the early morning hours from 2 to 4 am, when airway inflammation peaks, it is usually asthma. On the other hand, if a cough often worsens immediately after lying down or within an hour after meals, especially at night, it is usually GERD. Asthma is often accompanied by noisy breathing, shortness of breath, and chest tightness, and a history of allergies. GERD is more commonly related to heartburn, a sour taste, and a sense of regurgitation of food into the asthma improves significantly with inhaled corticosteroids and bronchodilators. GERD cough improves with proton pump inhibitors, antacids or lifestyle modifications, e.g. avoiding late meals, and asthma attack starts after exercise, cold air or allergens or respiratory infections. And a GERD cough is triggered by large meals, fatty foods, alcohol, and lying down after it. Second tip: if a cough is triggered by talking, laughing, or cold air, it is highly indicative of cough variant asthma or laryngeal hypersensitivity syndrome. Cold air triggers bronchoconstriction. In this case, difficulty breathing or wheezing, noisy breathing may not be presented. The third tip: if a person has a tickling sensation in the throat with a dry cough which worsens with speaking, it suggests chronic cough hypersensitivity syndrome and is caused by overactive afferent nerves. This type of cough poorly responds to typical treatment, but may benefit from neuromodulators like gabapentin or amitriptyline. My fourth tip: if a person has constant throat clearing and globus sensation, a feeling of a lump in the throat, it strongly suggests postnasal drip syndrome or laryngopharyngeal reflux. This globus sensation is due to reflux-induced laryngeal irritation. Postnasal drip syndrome means when excess mucus from the nose drips down the throat and causes coughing. And laryngopharyngeal reflux is when acid comes from the stomach and reaches the throat and voice box. It irritates tissues and causes hoarseness, cough, and a lump-like sensation in the throat. It looks like acid reflux, but the difference is that heartburn is not a common symptom in the case of laryngopharyngeal reflux. Fifth, if a cough starts after a common cold and persists for weeks, it is called a post-infection cough. Such a cough usually will resolve within 8 weeks and is common after respiratory syncytial virus, influenza, and pertussis infections. In this case, a short course of inhaled corticosteroids is effective. Sixth, if a person has a morning cough with excessive mucus, particularly in long-time smokers, it indicates chronic bronchitis or bronchiectasis. In non-smokers, frequent purulent sputum should raise suspicion of bronchiectasis. A chest CT scan is often required for diagnosis. If a person has a productive cough more than 3 months for 2 consecutive years, it is very highly likely chronic bronchitis. Seventh, if a cough is triggered by pressure on the ear, it is called Arnold's reflex. It is common in people with earwax impaction or ear infections. So, if you have a tingling sensation or cough when cleaning the ears, it can be Arnold's reflex. Eighth, if a person is coughing up blood, it is called hemoptysis. Even a small amount of blood mixed with sputum should prompt investigation for lung cancer, tuberculosis, or bronchiectasis. Although, if a person has just a common cold or bronchitis, persistent coughing can irritate and rupture small blood vessels in the throat and cause coughing up a small amount of reduced mucus. But as a general rule, if a person is coughing up blood, especially recurrently, it always requires further investigation. And ninth, if a person takes ACE inhibitors such as lisinopril, captopril, or enalapril, there is up to a 30% chance they may develop a dry, non-productive cough. This side effect can begin anytime from a few days to several months after starting the medication.